So I think I have 30 minutes, and I have about 28 or so slides. I don't have to go through all of them. What I'm going to try and do is to give you a flavor for what is now possible with extremely large data sets. Now, extremely large is a relative thing. I don't think we have a big data problem in healthcare. Unless you touch genome and images, most of the data you can still fit in memory. So in that sense, it's not a big data problem. It is a big data problem in the sense you do have a big mess in terms of making sense of what you have. And we can get into that offline or over coffee or something. Right, so the title, Using Machine Learning in Healthcare or Building a Machine Learning Health System, actually give two options, and both are on the website, so you're still getting the same talk in case you read the agenda. So my group at Stanford, we're about 22 people, ranging from PhD computer scientists to pathologists to vascular surgeons to undergrads, med students, PhD grads in computer science and biomedical informatics. It's a pretty chaotic group in that sense. And we do three things. Most of them using very large electronic health record data sets, some of them using consumer search behavior data and patient blog data, which I'm not going to talk about today. Most of the stuff today is about EHRs. And then we do three buckets of projects. So we ask and answer clinical questions in a 4 to 6 month time frame to 24-hour turnaround time frame. We ask questions that doctors don't ask, and I call that generating insights, and we make predictions. In each bucket, there's at any given point about 10 to 12 projects. I'm not going to walk you through 30 projects. I'm going to pick one from each. And we'll start with the one that Somali already alluded to about this informatics consult, which is how do I make better decisions based on similar patients. And before I launch into these three examples, I want to show two pictures that provide a frame of reference for what we talk about and what I would want the XLDB community also to sort of help the physicians with. So all of these efforts and what I'm going to talk about is for this one mission, to bring AI into the clinic safely and ethically in 3 to 5 years. And in 5 years, if I don't do it, then you know I failed. So in that sense, it's a good, clear metric. I'll move on to something else. And being tenured, if you fail, you don't get fired, so it's good. All right, so healthcare happens over time. It's probably the most important thing to remember. Most of the times, what is shown to you are snapshots in time. So imagine a patient timeline, and then some stuff happening. So each black dot is something happening to them, having the flu, breaking a leg, whatever. And then you'll have some recording of it about what disease they had, what prescriptions were given to them, procedures, imaging, billing, streaming data if they were in the ICU at some point. And at some time, somebody will measure a genome from one physical location in the body, usually the cheek. And we love to believe that there's one genome. Open for debate whether it is one or not, and whether you take it from the cheek or somewhere else, do you get the same sequence? And you throw in sequencing errors, that's why people like Manny and others are still looking at the genome to figure out what's up there. Very few people measure the genome over time, other than the oncologists who do measure tumor evolution. So really important to have this frame of reference. And then we have this on many people. What will be given to you for the most part is what I call timeless data sets, or timeless data science, or timeless data frames, which is you'll see something like this, where the time axis, I just pivoted what we were looking at, and now the time, instead of going left to right, is going front to back. And what happens is that matrix is compressed, and you get a flat data frame. And you might get it from EHRs, you might get it from claims, you might get it from quantified self, where you might get the number of steps somebody took in a day or something, which is actually a trace over 24 hours of the normalized voltage of one-dimensional acceleration. That's what you're really getting. We pretend it's a count. And we trust somebody who we've never met to take that voltage and turn it into an integer, and we treat it as ground truth. So just to layer on all of the different uncertainty that goes in there. And then there's the genome, metabolome, the microbiome, and whatever other ohm you can think of, where you'll have lots of features measured, anywhere from 6 million to 3 billion, on a few humans once. So just to set that reference, and of course all of this will be compressed. So you'll get genome and you'll get the corresponding EHR, but the EHR is over 10 years. And then you have, at one point, you measured their genome. So keep that in mind. All right, so with that, and for the database community, this is kind of a tongue-in-cheek joke that our databases suck at handling time. Like, beyond belief. There's no good commercial systems that do interval algebra in a good way. So if I want to find patients who have X, not Y, and then had Z, but had no history of A, B, and C, I still have to write 4 pages of SQL or something similar. That's a problem worth solving. It's a very big problem in healthcare because healthcare is all about time. Okay, so I've spent 6 minutes already. So now we got 24 minutes and 3 examples to show, so about 8 minutes each. So let's just jump right in. We'll start with the clinical questions, and on that one, I'm just actually going to show you a video because I know it'll finish in 2.5 minutes.
Imagine you are a pediatric cardiologist seeing a new patient with an incidental diagnosis of atrial septal aneurysm. You wonder about the need for anticoagulation for such a patient and read the literature to find that there's limited evidence on how to manage such a case. How do you proceed with care of this patient? Physicians often face such uncertain situations for many reasons, such as a study answering the question has not been done yet, the available evidence is unreliable, or the evidence does not apply to their patient. In such situations, wouldn't it be amazing if physicians could leverage the experience of millions of past patient encounters instead of relying on anecdotal experiences or input from colleagues? The Clinical Informatics Consult makes it possible to aggregate data from over 150 million patient charts and obtain a summary of what happened in practice. These insights, derived from the accumulated experiences of other patients just like yours, enable precision in the practice of medicine. To provide our service, we first clean up the data present in the electronic health record. Then, using a novel search engine developed at Stanford, we generate patient cohorts in seconds and perform statistical analyses to provide an answer for your clinical question within days. To submit your request, all you need to do is email a question to greenbutton@stanford.edu with the following information: patient population of interest, intervention or exposure to study, description of the cohort you want to compare with, outcome of interest, and time frame over which the analysis should occur. Once we receive the consult question, one of our clinicians will work with you to refine the question. Our team will then perform the analysis and generate a report with an interpretation of what the results mean for your patient. Our clinicians will discuss the report with you and clarify any follow-up questions. Our service has already been used to answer diverse questions across multiple subspecialties. Realizing the vision of the Green Button, the power of aggregate patient data can now be brought to the bedside. The next time you are in an uncertain clinical situation and wonder what happened to other patients like mine, we'd love to help. To request a consult and see some example consults and reports, visit us at greenbutton.stanford.edu.
Right, so the name Green Button also has a very interesting history. We wanted to have there's this paper that just flashed by, one of the few papers I've written with no data. It's like a vision paper, or hallucination paper, you can call it. And we needed a mental picture, an image of what this functionality might be. So we envisioned a button in Epic. and then we needed to name it. And then blue button was taken by the patient data download by the VA and enabled by the government. And blue is the color of healthcare. So okay, so blue's gone. Can't have red in healthcare or orange or anything of that sort. And we thought of brown. And then I'm brown, and UPS could sue me, and I was like, not going there. Don't want to touch that whole sector. And then we asked ourselves, so what's the color of evidence? So evidence makes things clear, so it should be called the clear button or the clarify button. But no computer scientist would click on a clear button because it would delete your screen. So it's like, damn it, we're stuck. And so we left with the only primary color we had, which is green, and so that's why the green button. So that's the brief history behind that. All right, so I already showed you the video. And that's the URL if you want to see more about it. So for me, this journey started when I joined on the faculty on this campus, and this particular paper had just come out in the New England Journal of Medicine. And Jennifer Frankovich was tasked with having to treat a 13-year-old female with SLE, systemic lupus, erythematosus, and there's nothing in the textbook on how to manage this patient. And she ended up searching our clinical data warehouse using a cohort builder tool that Somali's team built, or builds, and continues to maintain. And she did some basic math, division to get some risk ratios, and made a treatment decision about the patient, because in this case, the patient had high proteinuria, and high proteinuria confers a high risk of having a thromboembolic event, and she used anticoagulation. Patient did fine. She got into trouble with everybody on campus. Legal, privacy, compliance, CEO, dean. And then after a while, so I was just joined, watching from the sidelines what the heck is going on. And then everyone thought this through and said, this is why patients come to Stanford. You would want the best decision based on all the evidence at hand. The hospital had seen 98 patients, the Lucille Packard Children's Hospital. No individual physician had. Why would you not aggregate the experience of those 98 patients? It's a simple idea. And so working with Chris Longhurst, who's a friend of mine who was the CMIO then, we said, couldn't we do this on a systematic basis? That's what led to the Green Button Vision paper, and then to the service that I just showed you the video of. So the basic idea is that if you have a clinical question and you know what to do, you have a guideline available, by all means go do it. If not, request a consult. We'll use the search engine, which was alluded to in the video, and then we'll do some analysis and produce a report that tells you, what happened to similar patients, our interpretation. We'll walk you through the research we did. If it doesn't work, of course, go use professional judgment. As a byproduct, now we know what are the questions that doctors are asking. So we've been running this service since July or August of 2017. We've done 60 consults to date, or as of 3-4 days ago, there might be 61 now. And across multiple service lines, and about, I would say, 10% of the time, we end up saying, can't help you, cannot give you any answer whatsoever. The majority of the consults, actually, to our surprise, ended up being descriptive questions, just asking how often does something happen, instead of the inferential questions that we were expecting, saying compare A versus B. Just a little close-up of the search engine itself. You have to learn this hideous syntax, but if you learn that, it does allow you to do temporal querying like nothing else. Every time I've shown this to computer scientists, including friends at a certain search engine company in Mountain View, they want to put UIs on it. They want to work with natural language processing to produce these queries themselves. Like, smart CS people, by all means, go ahead and do it. I got a team of 22, one software developer. I'm going to stick with the hideous syntax because the damn thing works. And I'm happy to show you videos of it and demos and so on. We can search across 150 million lives, complex queries with time, negation, text, ICD-9 codes, lab test results, and produce a set of matching patients in a few seconds. Because that's the part that typically takes 2 to 3 weeks. And if I reduce that to less than a minute, then I have the rest of the day to do the statistics and write the interpretation and explain what happened. So the parts that can be engineered out of the way, we engineered out of the way. The stats you can't engineer out of the way. You can't wish away confounding. And there you have to put a human in the loop. And then you can't wish away the fact that doctors don't get math. So you got to put another human in the loop to explain exactly what this means. And these are the two URLs where the first one will take you to the video that I just showed you and a few example reports of the consult. And the second one is a 2-minute video about just the search engine, the tool, which is used in this service. What we've done so far, this is an old histogram with about only 26 or so items in it. Now we're up to 60. We get questions that are just asking time to event rates, as in people with so-and-so, in this case hypertrophic cardiomyopathy, if I use beta blockers or calcium channel blockers, what's the time to stroke or whatever, heart failure? Now in your heart, you know that when they ask this question, they're going to interpret the result as a competitive effectiveness. So when you give the report back, you have to be very clear, saying, I'm telling you the report that the rate is lower with beta blockers and higher with calcium channel blockers does not mean that the beta blockers are better. And you have to underline that 5 times and you ask them, did you hear that? Can you repeat that back to me? Then the majority of the consults were descriptive, which is nice. It's counting. I feel very comfortable doing counting. And then a few were inferential, where patients prescribe ibuprofen. Is there a difference in peak glucose after you treat them with acetaminophen, and one or the other? This is a true inferential question. You know they're going to make a decision to prescribe ibuprofen or acetaminophen based on what you tell them. So you want to pull out your textbook of stats and do the best job you can, and also empirically quantify the chance that you got it wrong. And I say empirically quantify because with such large data sets with lots of features, up to 15,000, 20,000 features, millions of patients, if you go just for significance, everything will be significant just because you have a very large data set. So p-value is mostly pointless at this juncture. So you want to, and there are easy ways to do that. You can just make a list of 10 things that you know are definitely not true, like aspirin associating with pregnancy or something associating with left foot fracture but not with right foot fracture. Test those things, and the number of times those silly things turn out to be positive, that's your empirical chance of being wrong. And there's a lot of work in that domain from this Odyssey community that Somali also mentioned. Okay, lots of open questions of the form, are there other uses of the search engine? What is really useful, as in just a description of what happened, or should we give a population level estimation or an individual level prediction and so on? Lots of informatics research that needs to be done. And then most important and often ignored, the financial viability. Who would want to pay for this test? If you were a patient paying out of pocket, how many dollars would you be willing to pay to get a 3-page report of what happened to similar patients? Usually there's stunned silence, really? You have to pay for this? Okay. So right now it's funded by a foundation that chooses to remain anonymous, so at least for the next year or so we're good. All right, so the second bucket of examples is asking questions that a doctor doesn't ask. And so here there's usually sort of consensus about how certain things should be treated, and then parts of it where there isn't. So we looked at 3 diseases, and here we is this Odyssey community: hypertension, depression, and diabetes. And I'm going to show you diabetes. And we asked for all 3 diseases, what is the first drugs that somebody gets? What is the second drug they get? Third, fourth, fifth, sixth, we went all the way till 20. So this answers the question, what are doctors doing? So in this one, we're looking at diabetes. The first inner circle is the first drug somebody gets. It's green, so color tells you the drug. So metformin, about 75% of the time people get metformin. That is also what the guideline for diabetes management says, that you should be started treatment with metformin. For those that don't, it's very obvious when trivial to predict who will not get metformin. These are the folks with poor renal function, and they should not get metformin. So inner circle, life works as advertised. But then the guideline says if in 90 days your A1C is not controlled, pick a second-line drug. That's practically what it says, pick a second-line drug. And that's exactly what doctors do. They pick a second-line drug. So I just picked three, rosiglitazone, sitagliptin, and pioglitazone. 5 to 6%. Now we looked at about 250 million patients. And then we asked the question, which one of these three pathways are good? This is what they're doing, pure descriptive. Next step is, does it work? So data from about 7 sites and 4 countries. And we're asking the question that of these 3 arrows that you could go on after metformin, which one brings your A1C down faster? And which one has lower rates of renal, cardiac, and ophthalmic adverse events, which are the most common things you get if your diabetes is not under control. And then we can do a meta-analysis across all of these sites. And turns out that for getting your A1C down, all 3 are about the same. So you could just pick one. Sitagliptin does appear to have a slightly lower rate of adverse events, particularly renal adverse events. And I say appears because all the sites are not agreeing with each other, and it's only the meta-analysis that gives me significance. So, take it with a grain of salt. Okay, so I'm going to skip. I'll do this. I have 10 more minutes. Okay. So the other kind of questions we're doing, what doctors should ask but don't, is we're asking what diseases follow each other. And this is based on data from the Truven market scan data. It's about 140, 150 million lives over 5 years. And we're looking at patients with 2+ diseases in, say, 2009. And we do this for all 5 years or 7 years we have data for. And across all 50 states, we'll construct a profile of the disease. So what we'll do is we'll take people who have the disease and people who don't, and then the disease of question becomes that yellow bar. That's the Y column that I'll regress against. Everything else they have, I'll regress against that to find what is the increased risk of getting this other thing if you already have one of these columns in gray. And we'll do that across the 50 states. We'll then do a meta-analysis, and then we'll do that across calendar years, so 2009, 10, 11, 12. And what I want to get at the end is those associations or risks where you have a higher probability of getting disease A if you already have disease B. That's what this red thing in the end is at the end. And so we get things like there's a higher chance of acne given you have eczema. And there's a higher chance of getting acquired hypothyroidism if you already have Down syndrome. And we do this for about 160 diseases, and then we get about 140 or so disease pairs that consistently follow each other across all 50 states, across multiple calendar years. And then we ask which one of these disease pairs have never been studied together. And we ended up with 9 disease pairs. This is the fancy picture, eye candy, that says there are these diseases A and B which are very strongly associated according to Truven market scan across all 50 states, across 5 calendar years, but there's no papers that mention the 2 of them together. So the point here is to find those disease associations that are happening in practice but we're completely missing. So that's a question a doctor wouldn't ask because that's not on their radar anyway. Okay. And then the last example is in the predictive modeling space, and I'll use the palliative care example. And the point of all of this predictive modeling business is to enable some action. And I only care about those predictions for which there is an alternative action for me to take. And I'm also not interested in predictions that are just classifications masquerading as predictions, as in you look at an image and you predict it's a dog. I mean, it's a dog before you predict it's a dog. You just figured it out. There's some value in doing those kinds of predictions, classification kinds, but I'm not going to talk about that today. The only thing I'll say is you can use those kinds of supervised learning-based settings to figure out who has undiagnosed genetic disease. And I have a worked out example of that, but that's not something I'll have time to discuss today. All right, so let's go to palliative care. This is a map of the quality of palliative care that you get in the US. Red means bad, blue is good. It has nothing to do with politics, I promise you that, but it does look eerily similar. And the sad truth about palliative care is about that 90% of hospitals with more than 300 beds will offer palliative care. The estimated demand or need is about 7 to 8% of the admitted patients, but only 3.4% admissions get palliative care. Stanford is at 3.5, so we count amongst the better ones. And the model for palliative care is a pull model. So palliative care would, this is a treating physician, bedside physician. If they think palliative care is necessary, they will pull the specialty service line and say, can you see this patient? So now you're gated by the ability or time or having time of this person, the treating physician, to invoke a palliative care consult. What we think, and the way the effectiveness of this is shown by these numbers. So of the about 131,000 patients that have died in the hospital in the past, whatever, 10 years or so, we're asking how many of them got palliative care. So that's V66.7. So 4,657 did, and that's 3.55%. And then we asked how many of them got palliative care consultation 6 months prior to death. 0.08%. It's terrible. It's too little, it's too late. And then there's prospective clinical studies showing that when you're offered palliative care, people have a better quality of life, they live longer, and they cost less. There's no excuse not to do this. And palliative care has more to do than just end of life, but for this discussion we can pretend it's just end of life, but there's more things in palliative care. All right, so what we thought could happen is that we have people admitted, an algorithm can go through this and flag a patient that the palliative care physician should see, and they proactively reach out to the treating physician, not to the patient, and the algorithm itself is not making any decisions. And the reason to do this is about 80 patients get admitted every night. If I ask the palliative care service to manually review the chart for all of those 80 patients at even 5 minutes a chart, we're talking 400 minutes, which is a lot of time. But if an algorithm can go through it and then flag the 6 people that palliative care needs to review the charts of, I've reduced those 400 minutes to about 18, which is much more manageable. And so that's what we built. Now it's very hard to get supervised training data, labeled training data for is the person eligible for palliative care. So now we're using a surrogate. We're going to use death as a proxy and say whoever died should have been offered palliative care. Okay, so that's a slight pivot. I'm not building the model for the thing I want to build a model for, I'm building a model for something else. And we trained this classifier. And so we have a certain time point at which we make the prediction. We spent a lot of time debating what our observation window would be, that how much prior record we should be using. And I can tell you lots of experiments about 6 months, 1 year, how do you handle time, how do you featureize time, should you bother, should you not bother. And then a lot of conversations with the physicians to say, what window is worth predicting? Because there's a lot of, if you read the literature, you would arrive at a conclusion that you should build a model for 24-hour mortality. Complete waste of time. Absolute waste of time. Because there's not much you can do at that point. Because in order for the ground logistics of the healthcare system to happen, the 2-week to schedule an appointment, a nurse to call you, and conversations to happen, you need a good amount of lead time. And so it turns out in palliative care, about 3 months is the minimum. that if you have that much time, you can hope to talk to the physician, you can hope to locate the patient, have a conversation with them in the right frame of reference, and so on. And about 1 year is the max out, because if it's further out, the person's not ready to have that conversation, and then you're just wasting time. And then these are just plots showing how good the model is. On the left is the AUPRC. AUC is useless in this. AUROC is useless because it's a low prevalence event. So you want to look at area under the precision recall curve. And then calibration plot. Because if we're going to make decisions based on this model better be well calibrated. So if I put a high probability of somebody dying, they better actually have a high probability. That's the gist of it. Without calibration, you can't use prediction models for patient-level decision-making. Another sort of secret that is happily ignored in the published literature, people report AUROCs for low-probability events. You always get good-looking AUROCs above 80, above 90, and then at some point it's just getting a paper published. So behind the scenes, what happens is that we read data from the clinical data warehouse that Somali's team manages, and that's what we use to learn the model. And then we get access to a daily refresh of people who got admitted like today. So at midnight, I'll know who got admitted today. The data warehouse will find out 24 hours later. So we pull that data, we apply our model, we write the result back, and then a report goes out every morning to the palliative care service line chief to say, here are the 6 or 8 people whose chart you should review. That's all the model does. It reduces the set of 80 to 6 to 8. Stephanie Harmon reviews these and then decides to follow up, and in their pilot testing, she follows up about 60% of the time. In the other cases, it's still a correct prediction, as in if we wait a year, the person will die in the next 3 to 12 months, but they're just not a good candidate for the conversation around palliative care, because our objective that we're training for and the actual use case are slightly different. Okay. And then to close this out, we also have to worry about the safety, the ethics, the utility. I worry about them in this order. It has to be useful first, and then I'll choose to worry about safety and ethics. I am not interested in ethics and safety discussion about something that's useless. So when you see a model, ask about the kind of use case. So is it a medical use case, an operational use case? I just showed you a prognostic medical use case. Figure out who is going to take the action. Who will decide? Is it a human? In this case, a palliative care physician will decide on the follow-up action, and the follow-up action is having a conversation with the treating doctor. And what assumptions are being made about the existence of an alternative action, the need for interpretability? In this case, there's no need for interpretability, actually. As long as it's right, it's good enough. And then the incentives and the ability to take action, because if I make 15 predictions and they don't get enough time to review their charts, again, it's pointless. So you might want to jack up your precision at the expense of some recall, just so that you retain the ability to take follow-up action. And we're wrapping all of this up into something I'm calling the Program for AI in Healthcare, with the simple aim to write a how-to manual on how do you get these kind of gizmos into practice safely and ethically. And there's training involved, there's the deployment. I gave you the example of palliative care. There's partnerships with companies. Most of this is already public information. There's a paper coming out with Google on May 8th. It's already on archive. And then the last piece is designing for utility, looking at the cost, the logistics, the lead time, all of those things that I referred to. And I'll bring you back to this mission statement. That's what we're here to do. And in the past year, we've done 4 efforts, including on the safety and the ethics, and figuring out what is the right way to put these things into clinical practice. And this is the one, this is the paper that's coming out. In fact, someone from Google, Alvin, the first author, is presenting at noon today in one of the seminar classes. And of course, none of this can happen with the efforts of lots of people. So this is a sampling of the 22 people right now. And these are the people who are past members of that of the group, funding from a lot of different sources. And I always like to say this: in 2014 we had a vision, and 2017 we actually have a service engine that makes a search engine that makes this happen, and the service is live. Thank you. So, yeah, a great question, as in, are we trying to limit ourselves to reasonably predictable events? No. And the reason for that is I want my model performance to suffer as a result of that mess that real life throws at you. Because I want real world estimates of performance, both of the predictive accuracy and of the calibration. So we could do that and make my numbers look better. And from a modeling perspective, one might argue that that is the right hygiene. But in practice, I want to be able to quote a number and say, this is going to work for any admission, and I'll take a performance hit for those kinds of things. Yeah, so it's a great question. I have a $3 million answer to that. I'm not joking. So we spun out a company in 2013 and very quickly realized, and I say 3 million because we raised 3 million and there were people willing to fund it just on the promise of it. But very quickly we realized the issue that you bring up, that a query language that is needed for running the service is not enough justification to build a product. Now, it turns out that in theory, you could take all the constructs of this query language and map them onto SQL constructs and then optimize the heck out of your relational database so that you have this domain-specific language layered on top of your relational algebra. Doing that versus implementing a query processor from scratch, it just turned out that implementing from scratch was at least an order of magnitude, or if not more, cheaper and faster. So all of the search engine, which you can look up the video, is built by one human in less than 6 to 8 months. It's a very smart human, but if I wanted to overlay that on relational algebra and then essentially plug in Postgres or MySQL or something else over there, I would need at least 5, 6 people and 3 times the time.